I'm actually presenting the same perspective as Dr. Sara. I don't think we're opponents in this because I'm for, if you find the case of microspherophakia, maybe you should consider keeping the lens and observing. So this is, first of all, I'd like to thank Dr. Dina because this is a case courtesy of Dr. Dina Hussein. This is a 7-year-old patient presenting with myopia of -6 diopters and astigmatism -1.5. Her best corrected visual acuity was 0.8, and she was complaining of intermittent headaches. Intraocular pressure was found to be high bilaterally and uncontrolled on medical treatment. And on examination, we found that she had a very shallow anterior chamber bilaterally, and the lens on dilatation was found to be globular, clear, and in place. We performed the biometry, and the axial length was found to be 21 millimeters. Her K readings were normal, 42 and 44. Anterior chamber was very shallow, so this led us to the conclusion that this is a refractive myopia. To further confirm this, we performed a pentacam and found that this refractive myopia is not related to the cornea. Her K readings were normal, and her corneal thickness was also very good. So this was a case of microspherophakia. Again, I'm just going to go through quickly. Microspherophakia is a congenital anomaly, commonly bilateral. The genetic disorders, such as Dr. Sara said, in Ville-Marchesani, Marfan, Alport, or Klinefelter syndrome, the lens is small and spherical, with an increase in anteroposterior diameter and decreased equatorial diameter. And because of the weak and poor attachment of the posterior zonules to the ciliary body, it allows the lens to move forward and backwards with change in posture. So the Schimflug images were very confirming to the diagnosis, where we can see a very shallow anterior chamber, almost 1.3 millimeters bilaterally. The lens has a very small equatorial diameter and a very large anteroposterior diameter. It's almost spherical. Again, we can see that there is also a bilateral pupillary block. Fundus examination showed that the fundus was normal, and the optic disc looks pretty healthy with a cup disc ratio approximately of 0.4. Especially in this young age group where you cannot perform biometry, you need to perform an optic nerve analysis, because this is your baseline to further follow up the patient and find out if there is any damage. In this case, her both retinal nerve fiber layer and ganglion cell complex were within normal. Again, we have to take into consideration that there is no normative data for this age group, and therefore you will have to treasure this OCT as your baseline. So how would we manage this case? Would we continue medical treatment and give it for life and risk optic nerve or field affection? Would we go ahead with glaucoma surgery, or would we perform a lensectomy given that her vision is 6/6? And where would we place an IOL in the absence of capsular support? We debated the use of miotics, and miotic agents often aggravate pupillary block in microspherophakia because they cause the contraction of the ciliary body and relaxation of the zonules, allowing the lens to move forward and cause pupillary block. How about mydriatics? Mydriatics also are a two-way issue, because if the zonules are intact, you can use a cycloplegic agent to relax the ciliary body and therefore pull on the zonules and allow the lens to move posteriorly, relieving a pupillary block. But if the zonules are not intact, you have dilated your pupil, and this lens is free to jump into the anterior chamber, causing endothelial damage and glaucoma. So we opted for bilateral surgical iridectomies to relieve the pupillary block and the intermittent headache that the patient is complaining of, and also give her glasses. So microspherophakia and glaucoma are actually coupled hand in hand, and in fact the primary cause of visual loss in these patients. They are usually, many of them have found developmental angle anomalies, and the lens removal alone is not enough. And the incidence of glaucoma is very high, 40 to 50%. The mechanisms, as Dr. Sara said, from chronic pupillary block resulting in peripheral anterior synechia, or the chronic pupillary block in itself, even without angle closure, reverse glaucoma from the use of miotics, or crowding of the lens by the spherophakic lens, the presence of angle abnormalities or agenesis of angle structures, and has also been reported with an open angle. So Sometimes the first presenting symptoms of a spherophakic lens is by a bilateral acute angle closure glaucoma, as just seen in this 45-year-old woman who complained of bilateral acute angle closure glaucoma, and the lens was found to be small and spherical. She underdid plus planar lensectomy and anterior vitrectomy. Therefore, you should look out for any angle closure for a microspherical lens. The visual outcome is also closely related to glaucoma. In a study in the eye, 36 eyes were studied of 18 patients. The degree, they all had some form of lenticular myopia. 50% had high intraocular pressure. Glaucoma developed in 44% of the cases, and despite medical and surgical management, the intraocular pressure remained high in 5 eyes, and 16 eyes required lensectomy, and this lensectomy did not have any impact on the intraocular pressure. Therefore, in conclusion, microspherophakia is associated with a high incidence of lenticular myopia, subluxation, and glaucoma. Management of glaucoma is very difficult, and the intraocular pressure can remain high in 30% of the patient despite medical and surgical management, and there is no protective rule for lensectomy and had no effect on intraocular pressure. Thank you.